Welcome to the Nursing 158 Cellular Regulation Lecture. Right, the first thing we're going to look at today is the non-stress test. This is a test that would be done antenatally to determine fetal well-being by looking at the changes in the fetal heart rate pattern. What we know is that an adequately oxygenated fetus with an intact central nervous system should demonstrate accelerated fetal heart rate in response to fetal movement. The advantages for a non-stress test is that it's quick to perform, it's non-invasive, it's easily interpreted, it's inexpensive, and really there's no contraindications or side effects because we're just monitoring externally. Disadvantages, though, could be that it can be difficult to get a suitable tracing that we can interpret. Women must remain relatively still for at least 20 minutes to complete the test. There is a high false positive rate, and it is less sensitive in detecting fetal compromise than the contraction stress test or the biophysical profile. In terms of positioning for your non-stress test, we want mom to be reclining in a chair or in bed. She can be on a left tilt, semi-Fowler's position, or even side lying. As long as we completely avoid the supine position to avoid vena cava syndrome. Equipment that we're going to need for this procedure is the electronic fetal monitor, a Doppler transducer, which is going to monitor and record the fetal heart rate, the Toco transducer, which is going to monitor and record any uterine activity such as contractions, and a handheld button to mark any fetal movement. So if you look at this picture here, we have mom on the monitor. You can see that there's two. The top monitor is probably the Toco transducer, so this one is monitoring for any kind of contractions or uterine activity. The next one here above the baby is going to be the Doppler transducer to pick up the fetal heart rate. And then you can see that both of those cords are connected to the electronic fetal monitor, which is then giving us an output of the tracing. You'll also notice that mom has that handheld button in her hand, and as she's laying there during the test, she is told that anytime she feels the baby move, that she presses the clicker. And then what that's going to do is the clicker will mark on that fetal monitoring strip the tracing that's coming out. It's going to show marks of where mom pushed the button, where she felt the baby move. And then we can see if there are elevations or accelerations in the fetal heart rate that correspond to when she felt the movements. Okay. Underneath our picture is a mnemonic that tells us that a non-reactive, non-stress test is not good. Okay, so that takes us to our non-stress test interpretation. Your results are either reactive or non-reactive. All right, so as we just saw, non-reactive is not good. We want this reactive result. Okay, remember your terminology. For a non-stress test, it's a reactive result. Okay. A reactive stress test means that we saw at least 2 accelerations of the fetal heart rate with fetal movements of 15 beats lasting 15 seconds or more over a 20-minute period. In preterm fetuses, an acceleration is considered 10 beats above baseline for 10 seconds instead of 15 by 15. But we still test them for 20 minutes. If we see heart rate decelerations, or the heart rate is going to drop below baseline, then the healthcare provider needs to be notified. All right, so to give you an idea of what we're talking about when we're talking about accelerations, decelerations, 15 by 15, all of that, if you look at your screen, you can see that this is the display. This would be an example of a tracing that would come out of the monitor. The top portion is the fetal portion where we can see the fetal heart rate and any patterns. And then the bottom portion is actually mom's contractions or any uterine activity. Okay, so in this top fetal portion for the non-stress test, this is the part we're paying attention to, is just the fetal portion. Okay, so you can see on the far left side that I've indicated with a yellow box, this marks where the fetal heart rate is. Okay, you'll notice that there is a blue shading across the strip, and if you look at the numbers on the sides again, you can see that it goes from 110 to 160. So this is a quick glance method of marking a normal fetal heart rate, okay, which is 110 to 160 beats per minute. Okay, so every line that you go up 10 beats per minute. Okay, as you go across the strip, you're going to see little boxes. Each little box is 10 seconds across. Okay, so it's 10 beats up and 10 seconds across. Okay, and then you'll notice that you have thick lines on this particular strip. They're bolded in red for you, and you can see that each area between the bolded lines is 1 minute. So what you should see is 6 small boxes going across from thick line to thick line, each one being 10 seconds. So that's going to give you 60 seconds or 1 minute. Okay. Now down in the contraction area, this is the same as far as the boxes going across are also 10 seconds, and the thick lines are still 1 minute. But in the contraction section, you don't have the beats going up. We actually completely ignore the numbers that are on the side in the contraction area unless you have internal fetal monitoring, which at this point we do not. All right, so what makes an acceleration and a deceleration? An acceleration is when you see a jump up from the fetal heart rate baseline of 15 beats, lasting at least 15 seconds. Okay, so if you look at this top strip that's, kind of pink or red, you can see where the heart rate's wiggling around, where it's nice and steady. The baseline is approximately 150 beats per minute. And then from that 150, you see that we have circled some jumps up. These are considered accelerations. So look at the very first acceleration that you see, and you'll see that from the 150 line, it does jump up, even though, you know, it's kind of hard to tell. It does jump up 15 beats. 15 beats is only 1.5 boxes, right? Because each box is worth 10 beats going up or down. Okay? So now look at the second one and do from 150, all right? You go up at least 1.5 boxes. Okay? And same with the third one. Now all three of them, if you look from where the acceleration starts, so where that circle starts, and you go across to where the circle ends on each one of them, you will see that they last at least 15 seconds, which again is only 1.5 boxes across, and these exceed that. Okay, so these are accelerations. Decelerations are the opposite, okay? We're going to see a drop down from the fetal heart rate baseline of 15 beats, lasting at least 15 seconds. Okay, so again, you see your heart rate, and where it's nice and steady, it mostly hits the 130 line. Okay, and then what you see is you see dips down from 130. Okay, so if you look at the very beginning of that strip, it says onset of deceleration, and then you can see where it goes down into a valley, and then it comes back up, and that's the end of the deceleration. Okay, then notice the line is stable, so that's your fetal heart rate. So again, it's bouncing at about the 130 line, and then you're going to see it dip again. Okay, then it stabilizes, dips again, stabilizes a good bit longer, dips, stabilizes, and dips for the last time. Okay, so all of these dips are going to be decelerations. Now we know that they are true decelerations because if we start at the 130 line, okay, so pick a deceleration to measure and look at where the 130 line is. It's the line above 120 because everything is 10 beats going up or down. Okay, once you're on that 130 line, you can see that each deceleration goes down at least 15 beats. So again, at least 1.5 boxes. And from the beginning to the end of each deceleration is at least 15 seconds across, or 1.5 boxes across. Okay? So that gives us decelerations. Okay, so applying that to our non-stress test, this particular strip that we're looking at is considered reactive. Okay, so the first step is, are there accelerations? Okay, so again, just a reminder that each small box is 10 beats up or down by 10 seconds, and that goes across. Okay. If we were to find the fetal heart rate baseline, it's really hard to tell, but it's about 130 beats again. Okay. Now, what I've done here is I've circled the periodic changes for you. So this indicates that it's a change from the baseline. Okay. Now, you can see that these periodic changes do go up. And if we measure from the 130 baseline, they go up at least 15 beats. All of them do. And they last at least 15 seconds. So from beginning to end of the particular change, you've got at least 1.5 boxes. Okay, because they meet the 15 by 15 rule, and they're going up from baseline, they are true accelerations. Okay, so this strip is reactive because we see at least 2 accelerations. We've actually got 5 up here of the fetal heart rate with fetal movements that are 15 beats lasting 15 seconds or more. So yes, they're true accelerations. They meet the 15 by 15 rule, and it would be over a 20-minute period. Now, technically, this strip on your screen is approximately 12 minutes, but we've already met our requirement. Okay, so we already know it's reactive. Okay, so this strip now is showing you what a non-reactive, non-stress test would look like. Okay, so do you see any accelerations? No. Okay, because if you look at the line, you can see that the heart rate is very steady, and it's definitely a baseline of 130. There are no heart rate movements up from baseline that meet 15 beats up, lasting at least 15 seconds across. Okay, so therefore this strip is non-reactive because there are not at least 2 accelerations that meet 15 by 15 in a 20-minute period. However, notice that I've marked on this strip that it's actually only 9 minutes. So even though this is non-reactive here, we would need to complete the entire 20-minute test to see if maybe we get those 2 accelerations towards the end. As long as they're there within 20 minutes, we could call it reactive, okay? But if this were a 20-minute strip and this is what we were looking at, then it is non-reactive. Right, your next test is the contraction stress test. The purpose of the contraction stress test is to evaluate placental respiratory function. So we're looking at oxygen and carbon dioxide exchange. Okay, it allows us to identify any fetus that's at risk for intrauterine asphyxia. So in other words, if you remember, during the peak of a contraction, there is no blood flow to baby, which also means there's no oxygenation. So I need to know if I have enough oxygenation reserve on hand for labor. Okay? And contraction stress test is one of the methods we can use to see if our baby is going to tolerate labor, if we have enough oxygen reserve. Compared to the non-stress test, the advantages are we can get an earlier warning of fetal compromise, and there's less false positive results. Disadvantages, though, is that it is more time consuming, it is expensive, and it is invasive, okay? Because more than likely we're going to stimulate those contractions with oxytocin, which is going to be given intravenously. So because we are stimulating contractions, we should not perform this test on any woman who should not give birth vaginally at the time the test is done. Okay, so think about it. If you have a mom who is preterm, we are not going to do a contraction stress test because the risk is that we will end up putting mom into labor and then delivering this baby. All right, so true firm contraindications, which mean we will not perform a contraction stress test, are going to be in the cases of preterm labor, something called placenta previa, vasa previa, cervical insufficiency, multiple gestation, or a classical incision from a prior cesarean birth. Okay. With all these conditions, if we were to do a contraction stress test, we may induce labor, for which we actually do not want to do in these conditions, or we could cause some type of vaginal bleeding, or we could cause uterine rupture. Positioning for your contraction stress tests. So she's going to be in a semi-Fowler, or she's going to sit in a reclining chair with a slight lateral tilt. So remember, we are never fully supine. Equipment. All right, so you can see in the picture, again, we have our electronic fetal monitor. We've got the TOCO transducer for uterine activity, and we've got the Doppler transducer to monitor our baby. And then notice we have an extra equipment here. We've got the IV pole with the IV line and fluids. So this is going to be oxytocin to stimulate those contractions. We have all our intravenous equipment, and an infusion pump so we can infuse the oxytocin into mom. All right, so one thing to remember, oxytocin, even though we're using really small doses, it's an extremely powerful drug. So anytime we're going to use it, especially in the case of a contraction stress test, all we want to do is test. We don't want to actually put mom into labor. We absolutely have got to have tocolytic medications at the bedside. Okay, so TOCO stands for contractions. Lytic could mean lysis, like stop or death. All right, so we are going to stop contractions with tocolytic medications. Okay, so again, for the procedure, we need contractions. So we're probably inducing them with either oxytocin through an IV line, or we can actually have mom self-stimulate her breast, do some nipple stimulation, which in turn releases natural oxytocin in the body. Okay. We're going to need a 10 to 20 minute baseline recording of uterine activity and a fetal heart rate. All right, and then we're going to evaluate our tracing for evidence of spontaneous contractions. If we see 3 spontaneous contractions that are good quality, they last 40 to 60 seconds, that occur in a 10-minute window, then the results are evaluated and your test is concluded. All right, so that takes us to the interpretation of a contraction stress test. So results are either negative, positive, or unsatisfactory. Okay. For negative contraction stress test results, we have at least 3 uterine contractions in a 10-minute period with no late or variable decels. Okay, that is fantastic. That is exactly what we want. Okay. For positive, this is when we have late decelerations that occur with 50% or more contractions, even if we have less than 3 contractions in 10 minutes. Okay. In this situation, we may need hospital admission for further evaluation or immediate delivery. Okay. On the other hand, if we have a negative result, which is what we want, all we're going to do is give mom her results, explain the test and the results to her, and we're going to send her home. Unsatisfactory results. This is when there's a failure to produce 3 uterine contractions in a 10-minute window, or the inability to trace the fetal heart rate. Okay, so we just can't get a good tracing of our baby. All right, in this case, again, we need some further evaluation. So we'll either just keep her there and continue to monitor for a prolonged period, or we may decide to repeat our contraction stress test the next day. Right, so this is what a negative contraction stress test would look like. Okay, now this is a 9-minute strip, but you can see we just need 1 extra minute to fully conclude that this is a negative strip. But we've already met our qualifications. Okay, so if you look up at the top, this is our fetal portion, remember. Again, hard to establish a baseline, but we would say that the baseline is approximately 140. And then you can see down in the maternal portion, there are 3 contractions. Okay, and good contractions. They last at least 40 to 60 seconds, right? So that's 4 to 6 boxes across. All right, so when we look at the baseline of 140, we don't see any of those decelerations, right? We don't see anything that dips down 15 by 15 and lasts. Okay, so therefore we have a good strip, which means it's negative. Negative in this case is good. 3 contractions in a 10-minute period, no late or variable decels. Next is an example of what a positive contraction stress test would look like. Right? So again, first we note at the bottom where the uterine activity is being monitored, we can see that there are at least 3 contractions that are good 40 to 60 second contractions. We actually have 4 of them. Right? In the top, where the fetal monitoring portion is, you'll see the red circles, and the red circles are indicating that we have drops from the fetal heart rate baseline. So if we determine our baseline in between those periodic changes, and we see that it runs along the 120 beats per minute line, and then if we start at that 120 line and we measure these dips, they do go down at least 15 beats. So remember, that's only a box and a half. And from beginning to end, they last at least 15 seconds going across. So they do meet the 15 by 15 requirement to make them decelerations. So this particular strip is positive, which is a bad thing, because we do see late decelerations occurring with 50% or more of contractions. All right, we see that they occur with all of our contractions in a 10-minute period. Now, actually, this is, 12 minutes, but it would still meet the requirements if we took 2 minutes off. All right, and now we're going to move to labor induction. So induction is when we actually stimulate uterine contractions before the spontaneous onset of labor, with or without ruptured membranes, for the purpose of accomplishing birth. Another term that you're going to hear is labor augmentation. Augmentation is when we already have spontaneous contractions, but they're very weak and wimpy. So therefore, they're not effective in causing the progress of labor. Right? So some indications for why we may decide to induce labor include diabetes, preeclampsia and eclampsia, which are both high blood pressure problems during pregnancy, premature rupture of membranes. So this is when the membranes have ruptured prior to the onset of labor. Chorioamnionitis, which this would actually be an infection of the chorion and the amnion of that lining. A post-term pregnancy, intrauterine fetal death, intrauterine growth restriction. So in the cases of intrauterine growth restriction, we know that our baby is not growing because there is a problem, and usually the problem is the perfusion of the placenta. So this has no longer become a safe environment. Alloimmunization. So this is when your mom develops antibodies against your baby's blood and therefore attempts to attack the baby. Or any non-reassuring antepartum testing. So for example, like our contraction and non-stress test that we just looked at, if we had results that we didn't like, that were not good, then we may want to induce labor. Now, any contraindication to spontaneous labor or vaginal birth are contraindications of labor induction. In other words, if there is any reason that we don't want mom to labor or deliver vaginally, then we should not induce her. Right? Before we can begin labor induction, we have to assess for readiness, okay, the body's readiness. So first, we need to know the gestational age of the pregnancy. We need to potentially perform amniotic fluid studies to look at lung maturity. So this is really going to be in the case of we have a preterm mom that has maybe preeclampsia and it's severe, so we need to get the baby out. But we also need to know if the baby is going to do well respiratory wise. Okay. And then we're going to look at something called the Bishop score. So the Bishop score is going to look at the cervical readiness of mom. And we'll talk about that more in a minute. All right, so one of the first procedures that potentially could be done is called an amniotomy. Amniotomy is the artificial rupture of membranes. Okay, so mom needs to be at least 2 centimeters dilated in order to have a ROM completed. They're going to use a tool called an amni hook. So it is a plastic stick basically, and at the end of it is a nice little sharp hook that they can nick the amniotic sac with and break the fluid. Or we can use a gloved finger, and in this case the gloved finger has what's almost like a tack at the end of it, and again we're going to break the amniotic sac. All right, the whole purpose of this amniotomy is to stimulate or induce labor. Okay, we may need to break her water in order to apply internal monitors, whether we need to internally monitor the baby or mom's contractions. We may need access to the fetal scalp to draw blood samples to monitor baby's pH. Fortunately, it's not done very often. Or we may just want to assess the amniotic fluid. Okay. So, nursing care for your procedure. All right, so you can see the fetal and contraction monitor in the top left. All right, so we're checking our fetal heart rate before the procedure, of course, and immediately afterwards. We need to make sure then that we assess for cord prolapse. So if you move down towards the bottom center, You can see that a cord prolapse is when the cord slips below the baby and actually presents before our baby. Okay, this is dangerous because in the case of prolapse, the cord is also going to become compressed, which is going to deny perfusion and oxygenation to our baby. Okay. When the fluids are broken, we do need to assess the amniotic fluid. So just like with any other fluid, you're looking at consistency, color, odor, amount. What makes it a little different is we want to know, is there any meconium or blood in our fluid? Okay. Over to the right, you'll see that we are limiting vaginal exams. So mom has already been ruptured. So now she is at risk of infection. Okay, so therefore we're going to limit vaginal exams that could potentially introduce pathogens. In line with infection, we're also monitoring mom's temperature every 2 hours. Okay, and then back down to the bottom left, we're going to do comfort care. So cleaning the perineum is needed and changing out those perineal pads is needed. Okay. Finally, don't forget, bottom right, you have to document. If you do not document it, it wasn't done. All right, your next potential procedure here would be what we call cervical ripening. So remember that cervical ripening is talking about the effacement and the softening of the cervix. Okay, we may use it at or near term to enhance the success and reduce time needed for labor induction when we don't want to continue pregnancy. It can hasten the beginning of labor, or it could even shorten the course of labor. All right, so one thing we're going to do, if you look bottom center, is the Bishop score. So remember, this is us looking to see if our cervix is ready for labor. Okay, and we're looking at what we call favorability. Okay, favorability of the cervix. So you can see what it is that we're looking at: position, consistency, effacement, dilation, and the baby station. We're going to score each one of those. We want a score of at least 8. Okay, 8 means that the cervix is favorable and will likely respond to Pitocin induction or oxytocin induction, same thing. If we're greater than 9, then we may not really need to do cervical ripening. Okay? Greater than 9 means that spontaneous labor is likely. Less than 8, though, our cervix is not favorable, and we definitely need a ripening agent to prepare the cervix for induction. So one concern that we have with cervical ripening, of course, is that we can cause hyperstimulation of the uterus. So we could potentially cause contractions. And remember, hyperstimulation are contractions that are back to back to back. Okay. Nursing care for our procedures. So we need to do mom's vital signs, of course. We need to do baby's vital signs. We're going to put mom on the monitor and do some continuous fetal monitoring. She needs to lie either on her side or with a wedge, under her right hip, or on that left side for at least an hour after the procedure. Okay, so what we're doing here is we are inserting either a gel or, a tablet, some kind of pill, whatever, and it's going into either the cervix, the vagina, and some can even be given rectally. Okay, so we need those medications to stay in and absorb and work. So therefore, we don't want it to fall right back out. So that's why mom needs to lay down for at least 60 minutes. Now that time does change according to the type of medication and the route. But for our purposes, we're going to just go with 60 minutes. Okay. So because she's going to be laying down for a long time, we need to make sure that she voids prior to the procedure. Okay, next we are going to do something potentially called stripping of the membranes. All right, so membrane stripping. This is a mechanical method of labor induction. What we do is we take a gloved finger and insert it into the internal os and rotate it 360 degrees twice to separate the amniotic membranes that are lying against the lower uterine segment. Right. This procedure is going to release prostaglandins that will actually stimulate contractions. It doesn't require any kind of monitoring or other assessments. It can even be done in the office, outpatient. Okay? It may or may not induce labor. If labor is initiated, it typically begins within 48 hours. All right, and keep in mind to tell your mom that it may cause bleeding as well. Then we have mechanical dilatation with an intracervical catheter. So really all this is we insert a balloon of a Foley catheter into the cervix and inflate it. The purpose is to actually stretch the cervix without any kind of fetal side effects. Disadvantage is that it is very difficult to place. It's very difficult to maintain the placement from the woman moving. And, there's limited to no ambulation. All right, then we have our chemical method of induction, which is the most commonly performed procedure. And this is going to be our oxytocin or pitocin infusion. Okay, so oxytocin is effective at producing contractions, that would be in the case of induction, or enhancing ineffective contractions. So remember, they're already there. We want them more effective. So augmenting. Okay. All right. Our goal is to produce stable contractions every 2 to 3 minutes that last 40 to 60 seconds and are of strong intensity. All right, how do I know it's effective? Is this treatment working? Well, as I produce contractions, remember that your contractions are going to cause effacement, dilation, and change in fetal station. So that's what we will monitor. Oxytocin is a very, very powerful, dangerous drug. So it requires very small, precise doses, and you must always use an infusion pump. Okay, so typically oxytocin is run as a secondary infusion, which means it's piggybacked into fluids such as normal saline or lactated ringers. The starting dose of pitocin is 10 units, which equals 1 milliunit per minute. And when you do the math, that's 6 milliliters per hour. So you can see it's a very, very small dose. Okay. Typically what you're going to see are standing orders for pitocin. And so as the nurse, you'll watch these standing orders, and as your mom meets certain criteria, you may increase or decrease the pitocin. Okay. One of the biggest risks of oxytocin induction is that tachysystole or hyperstimulation. So again, it's contractions back to back to back, no rest period. Because we are causing that muscle to contract and work so hard, don't forget that the potential is uterine rupture. Okay, so it is super important that we still palpate our uterus during and between contractions. Okay, all right, so how would I know that I had hypertonic contractions or tachysystole, hyperstimulation, all those words? Because if you saw contractions that were greater than 90 seconds, if they were less than 2 minutes apart, and we saw any kind of fetal distress, such as our decelerations, then we would know that one of those conditions is occurring and we would need to stop the pitocin. So here are the medications that we've covered. A little bit more about oxytocin, and reiterates what I've said. All right, notice, you've got your classes and actions, side effects, and nursing implications. Okay, so there's your pitocin for induction or augmentation. Then you've got the dinoprostone, which is the Cervidil or Prepradil that we saw in cervical ripening. And then the misoprostol or Cytotec, again, for cervical ripening. Okay, so I would definitely study this chart. couple things that are super important to know about uterotonic meds. So uterotonic meds, we're producing uterine tone, right? We're increasing the uterine tone. So we are at risk for hypertonic uterine activity or tachycystole. Technically, the definition of tachycystole is more than 5 contractions in 10 minutes, or single contractions lasting greater than or equal to 2 minutes, or contractions of normal duration occurring within 1 minute of each other, or an elevated resting tone greater than 20 millimeters of mercury with an intrauterine pressure catheter. All right, we need to watch for fetal heart rate non-reassuring patterns that would indicate that we need to stop the Pitocin, such as fetal tachycardia, bradycardia, something called decreased variability, and then late decelerations. If we were to see any of these issues, so tachycystole or non-reassuring patterns in our baby, stop your oxytocin. You're going to give an IV fluid bolus of 500 mLs of lactated ringers. Position mom side lying. Administer oxygen by face mask at 8 to 10 liters. Call the physician. And then you may or may not give what we call terbutaline, which is going to be a tocolytic per protocol. And then this final picture is showing you to give you an idea of what uterine hyperstimulation or tachycystole would look like. So if you look at the bottom, you can see that we've got about 7 minutes worth of a strip. The bottom is mom's contractions. And if you look, we definitely have 5 contractions in 7 minutes, which definitely meets hyperstimulation of greater than 5 contractions in 10 minutes.